Dear friends from all over the world, I want to welcome you to Genie in a Bottle, which is a very special place to talk about dentistry from the inside out in a new format. This is not a newscast, but it is. It's not a morning show, but it is. It's not a debate program, but it certainly is. And it's not a talk show as well, but it might be in the future. We have been presenting dentists from all over the world, specialists in many different areas of dentistry. Organized dentistry, dental school, private or public dentistry, world dentistry. Because everyone has a word in our dental global world. And we will try to keep you bringing voices from all corners of the dental globe. I want to extend my deepest gratitude to Colgate-Palmolive Mexico for supporting the production of this effort through the Mexican Dental Association. All of us, except the production, has agreed to appear in this project pro bono. And we are all responsible for our views on the topics discussed here. This is a new adventure for me as well. And I'm very honored to welcome my good friend Michael Glick to co-host this program with me. Please welcome Dr. Michael Glick from New York City. Hi, Mike.
Hi, Jaime, and thank you very much for including me in this very exciting endeavor. I think our health community is now faced with new challenges, and I'm so pleased today that we could have both Eve Cooney from University and Stephen Chalacon from the UK to help us here to clarify some of the biggest concerns that we are facing right now. We're going to talk more about specific topics they're going to talk about, but overall, we're going to focus on aerosol, we're going to focus on saliva, and hopefully by the end of this program, you will know much, much more about how to practice safer dentistry.
Okay, thank you, Mike. And we're just going to go around the globe with our ambassadors for this new program, Genie in a Bottle.
안녕하세요. 한국의 치과의사 오철입니다. 닥터 제이미 에델슨하고 닥터 마이클 글릭이 함께 IDA 아카데미에서 진행하시는 GE in the Battle이 전 세계 치과의사에게 유익한 정보와 알찬 내용의 온라인 덴탈 에듀케이션으로 성장하길 바랍니다. 한국에서는 현재 코로나19 바이러스에 대해서 전국이 검사와 격리 그리고 사회적 거리두기를 통해서 위기를 극복하고 재개를 위한 기지개를 폈습니다. 한국이라고 해서 특별한 방법이 있는 것은 아니고 가능한 최대한의 검사와 감염자의 치료와 격리 그리고 사회적 거리두기를 통해서 사회를 셧다운하지 않고 시민들이 경제활동을 지속할 수 있었습니다. 그러나 최근에 감염자가 전국 4명까지 줄어들었다가 다시 확산하는 일이 발생하고 있어서 아직도 긴장한 상태입니다. 한국의 치과계는 일단 진료를 계속하고 있습니다. 방역의 수단은 기본적인 소독의 원칙을 지키는 것 이외에 추가적으로 할 수 있는 소독을 더하는 정도입니다. 체온 측정에서 발열이 있는 환자의 병원 진입 금지하고 마스크, 손위생, 개인 보호구 착용, 진료 전 환자 가글, 환자 진료 후에 체와 원내 소독을 더하는 정도로 하고 있습니다. 코로나 감염 환자가 병원에 방문하면 한국에서 병원은 2주간 문을 닫아야 합니다. 팬데믹 감염은 혼자서 잘한다고 해결되는 문제가 아니고 전 세계가 서로 협력해야 극복할 수 있습니다. 그래서 본인이 감염을 피해야 하고 전파를 하지 않도록 주의해야 합니다. 그것이 곧 세상을 돕는 길입니다. 세계화가 진행되면서 우리는 이기적으로 살지 말고 서로를 위해서 살아가라는 교훈을 코로나가 주고 있는 것 같습니다. IDA 아카데미아가 팬데믹 상황에서 치과계에 도움이 되는 영상을 만드는 것을 응원하고 앞으로 정보와 교육을 통해 치과계에 기여하길 바랍니다. 감사합니다.
Hola colegas, aquí desde Costa Rica, este es el reporte de la situación. Tenemos 10 semanas de que se apareció el primer caso. Conforme fueron apareciendo más casos, las autoridades de salud fueron incrementando las restricciones que íbamos a tener. Hubo una recomendación por parte del Colegio de Cirujanos Dentistas de Costa Rica y una directriz del Ministerio de Salud para atender solamente emergencias. Dentro de las restricciones de circulación y otras que se han ido implementando, siempre ha existido la libertad para que los servicios de salud continúen operando normalmente y para que las personas puedan atender citas médicas. Ya en 10 semanas, hoy 19 de mayo, les comento que el día de ayer se empezaron a suavizar las restricciones, ya se permite apertura de restaurantes entre semana hasta las 10 de la noche, hay aperturas de playas en horas de la mañana, 3 horas diarias, se han abierto algunos parques nacionales y algunos parques para práctica deportiva. Entonces ha iniciado un proceso de relajación de medidas. La mayoría de las prácticas odontológicas ya han vuelto a la consulta regular y conforme se vaya viendo si hay aparición o no de nuevos casos, entonces en ese momento se verán qué tanto se podrían seguir relajando las medidas. Tenemos en este momento poco más de 900 casos y al día de hoy acumuladas 10 muertes por COVID-19.
Hello everyone, my name is Hao Kim Chuan. Today I'd like to share with you the war against COVID-19, the Malaysian experience. Our first reported case of COVID-19 was on the 25th of January, where we have very low number until in the beginning of March. Our number suddenly risen from less than 30 to more than 2,000 active cases within a period of 2 weeks. And this has actually shocked everyone. The government swiftly introduced what we call a movement control order. The first 2 weeks, we still see number of cases increasing daily. And then it was extended for another 2 weeks. Then we noticed that it began to show signs of plateau. And we extend for another 2 weeks. And we begin to see the number going down. So we would like to share with you the Malaysian experience in fighting the COVID-19. Stay tuned.
Hola a todos los colegas que por este medio se conectaron. Los saluda su servidor, el doctor Sergio Curiel, a cargo de la Coordinación de Educación Continua de la Asociación Dental Mexicana. Ante la situación que seguimos viviendo por la contingencia del COVID-19 y el estar en casa durante este periodo, nos es muy grato tener una educación continua en línea de calidad, sumando el apoyo y espacio que nos brinda Genie in the World. Y en esta capacitación nos da la oportunidad de tener conferencistas nacionales e internacionales de un alto nivel académico y profesional con temas muy actuales. Agradecemos a la doctora Blanca Sanz de Idea Academia por esta alianza, coordinado con profesionalismo por el doctor Jaime Edelson y el doctor Michael Glick. Reciban todos ustedes la bienvenida y reconocerles por el gran interés de estar siempre actualizados.
Hello. Thank you very much to all our ambassadors all over the world, from Korea to Costa Rica to Malaysia to León and San Francisco del Rincón, Guanajuato. This is a new experience for all of us, right, Mike?
Yes, and I'm looking forward to it, and I'm very much looking forward to hear both the science and more the practical side and how we're going to be able to cope with this new challenge. And obviously, as with every challenge, there are also going to be opportunities here. So hopefully we're going to learn something from this challenge. They're going to make us much better healthcare professionals as well.
Okay, why don't you introduce our panelists of this morning, afternoon, or night, depends on which part of the, oh, no, wait. We're going to go to a short capsule from Colgate-Palmolive. Please, video can run.
Hola, ¿cómo estás? Buenas tardes. Esta es nuestra última cápsula de viernes en la cual vamos a hablar de prevención. Hoy ya nos informaron que vamos a empezar a trabajar, vamos a empezar a abrir más frecuente hasta el 15 de junio. Entonces tenemos todavía algunos días en los cuales estaremos con el paciente, que puede ser que tengamos un paciente con mucha sensibilidad, que tengamos un paciente con dolor que ha estado apretando los dientes. ¿Qué opciones le puedo dar si no voy a hacer una teleconsulta o si simplemente estoy viendo al paciente por WhatsApp? Y aquí la opción mejor es mandar fluoruro. Está bien documentado en la bibliografía y toda la evidencia científica nos muestran que grandes cantidades de fluoruro me van a ayudar a remineralizar la zona, va a tener un efecto bactericida, no se van a acumular ahí bacterias, y al mismo tiempo me va a ayudar a disminuir sensibilidad dental. En México ya hay productos con 5,000 partes por millón de fluoruro. Les enseño uno por acá. Esta es un gel dental que está mandado principalmente para ortodoncia, pero la ventaja grande que tiene es que 5,000 partes por millón de fluoruro. Si yo coloco esto en el paciente que se le fracturó la restauración, en el paciente que tiene mucha sensibilidad porque ha estado rechinando dientes, en el paciente que tiene alguna lesión cariosa activa, me va a dar tiempo para seguir trabajando. Obviamente tengo que seguir evaluando el riesgo del paciente y saber, dependiendo de las características, la cantidad de saliva y las indicaciones que me está dando el paciente o sus síntomas, podré decidir cuál es el producto y la cantidad de fluoruro que puedo mandar.
Okay. Now, Mike, if you can please welcome our guests. Let me just give you a short explanation of what's happening here. Eve Cooney, hello.
Hello.
She is in San Francisco and University of the Pacific. And Stephen Chalacombe, hello.
Hello.
Stephen is in London. Mike is in New York. I'm in Mexico City. The people taking down the questions you're putting on social media are in the south of Mexico City, and the production is in León, Guanajuato. So anyway, Mike, can you introduce our first panelist this morning?
Yeah, it's a great pleasure to have both Eve Cooney and Steve Chalacombe with us here today. Eve, I've known both Eve and Stephen for a very long time. And what we're going to do is we're going to start with have Stephen talk a little bit about the oral mucosal immunity and saliva, specifically saliva as an infectious, possibly infectious fluid in the COVID pandemic. Stephen is a professor. He's the Martin Rushton Professor at King's College, University of London. And Eve is the Director of Environmental Health and Safety and Associate Dean of Global Affairs at the University of Pacific. But more importantly, both Eve and Stephen have been involved with these type of pandemic previously. I have known them now for many, many years. It started off with the HIV pandemic. So they're bringing tremendous amount of experience and knowledge to this program. Eve is intimately involved with infection control procedures that are being promulgated by CDC and other organizations all over the world. And Stephen has been very, very involved in learning or teaching us how the oral mucosa, specifically mucosal immunology works in protecting ourselves as well as our patients. So with that, Stephen, if you will be able to start off here with a little bit of science behind what we are doing, and then Eve will continue to build on the science and make it even more practical for all of us. So thank you both of you for coming, and we are very much looking forward to hearing both of your presentations.
Well, thank you, Michael, and thank you, Jaime, for inviting me and us. And thank you, everybody, for watching. I think this is going to be a very exciting evening for us all, and I'm very pleased to be part of it. Now, I've worked for most of my professional career on saliva in one way and another. And I think I would, with prejudice, say that it is one of the most important body fluids. But today, I want to just say some things about saliva in relation to the COVID-19 pandemic. Now, on this first slide, you will see at the top, I just want to point out two things. Now, not changing the slide just yet. On the top of the first slide, if you just go back one, please.
Podemos regresar una transparencia.
On the top right is the latest computer-generated version by Visual Sciences of the COVID-19 virus. But on the left is the very first picture taken of a coronavirus. And this was taken by June Almeida at my own hospital in 1964. However, next slide, please. What I'd like to do in these few minutes is just try and address these questions. What is the risk to dental healthcare workers? Is saliva a risky body fluid? And if so, why is that? I think I need to tell you about where the virus replicates, in particular relationship to the oral cavity. I'm going to convince you that saliva can be used for a diagnosis, but it may be in the questions rather than in my talk. And I just want to touch on what to do about it. This is going to be the domain of Dr. Cooney, but I've been working on povidone iodine in the oral cavity, and I'd like to say a word or two about that. Next slide, please. So the first question, are we a risky profession, so to speak? This is a complex slide, but it came out a couple of weeks ago from the US Department of Labor. And this particular slide is just to demonstrate they looked at the risk to every occupation for hundreds of occupations. And the further to the right on this slide you are, the more risky your occupation on the three parameters they use: physical proximity to patients, the exposure to COVID, or then contact with others. Anywhere in green, I think, is the contact with patients. And so it's just to convince you that those three arrows all relate to dental professions. Next slide, please. So, thank you. So on this slide, it's rather more digestible than seeing all those dots. It struck me that the three of the top four professions that were looked at were dental. And so, in theory at least, we have a high risk for the dental hygienists, the dental assistants, and the dentists themselves. And this is three of the top four out of hundreds of occupations. So the Department of Labor certainly thinks that dentistry is at risk. And of course, internationally, I don't want to depress people, but we have had 23 deaths of dentists around the world knowingly so far. Next slide, please. So in the last few weeks, there have been a lot of studies have come out, and several have looked at the concentration of coronavirus in saliva. And this particular work by Toe caught my eye. It's one of the first to show this. And next slide, please. And the next slide, if we look on the, that's it, on the left of this, you will see that on presentation to hospital, there are enormous amounts of infectious virus in saliva. And I've given a yellow arrow there, which indicates that the mean of the people admitted to hospital with corona, the mean was about 10 million infectious viral particles per mil. Let me put this into context. This is 10,000 viral particles for every microliter of saliva. So if those watching now would just lick their lips, I've just done that, you will have smeared 10 microliters to 15 microliters of saliva on your lips. That will be well over 100,000 viral particles out of coronavirus on your lips. So you can see that if you then go out kissing people and do those other nice things, we will be transferring that coronavirus. Next slide, please. There's another point on this slide, and that is the second half, this shows, I think, the natural ability of saliva, even under these circumstances, to gradually suppress the virus. And so you can see another yellow arrow that after about 8 or 9 days, the viral concentrations in saliva, and I've taken the liberty of drawing a blue line on there, so you can see the gradual drop. And this is actually without direct antiviral treatment. So this is the natural situation. So saliva gradually helps to reduce the viral load in saliva and in the oral cavity. And this is important in terms of what we think we should be doing in dentistry. So next slide, please. But the oral cavity is not the only place where there are high levels of virus. There's high levels of virus in the nasal cavity. And actually they can be almost as high as saliva. And they take longer, I think the evidence so far, they take longer to drop down to levels, back to normal levels, and maybe well over 2 weeks. But nevertheless, this tells me that saliva, there's a very good correlation between the numbers in saliva and the numbers in the nose. And so saliva can be used instead of the nose as a sampling, as a reproducible method of sampling for COVID. Next slide. So where does this activity occur? Many of you will know that the COVID virus binds to something called ACE2 receptors in the oral, in the body. And there's some nice work being done which shows that these receptors are present in salivary glands. And so the message there is that the epithelial cells lining the salivary glands are early targets, it appears, of the SARS or now the COVID-19 infection. So anything you see in red there, and I hope you can see that, is the receptor for the COVID virus. Do they activate? And the answer, next slide, just to give you the evidence base. And again, I've directed your attention with the yellow arrows that every dot or there is a COVID virus, a coronavirus binding in the salivary glands. So this says the oral cavity as a whole then is very susceptible to the occupation by coronavirus. And just to remind you, next slide, please. I think there is increasing evidence that this is in minor salivary glands. And the distribution of minor salivary glands is shown on this slide. And it's an impressive amount of the total oral mucosa, isn't it? The tongue, the sides of the tongue, the lips, of course, and the palate. We have hundreds and hundreds of minor salivary glands, all of which, in addition to the major glands, can be targets for coronavirus. So what should we do about it? Next slide, please. We and others have been working on povidone iodine. And here I've just listed, and I'm sorry if I'm just stepping slightly onto the toes of what you'll hear in a moment, but with Dr. Cooney, but I've listed here various antiseptic mouthwashes and their concentrations. But several of these have been shown to be effective in vitro against coronavirus. And some of those, I think the only one, and this is even that is not published, is effective in vivo. We have evidence that povidone iodine is effective in vivo in humans against coronavirus. And so we believe that it can be used in both the mouth and the nose. And the way to do that, I show on the next slide. On the next slide, please. And so we are proposing that the two-step process that you should apply to reduce the risk of cross-infection by coronavirus from your patients to the professionals in 2 steps. One is basically applying small volumes, 0.3 ml to the nose, 0.3 ml in each nostril. And the other is using 10 ml of a mouthwash of 0.5% povidone iodine, which is moved all around the mouth for 60 seconds and then gently dribbled or spat out. So we believe that this is a way of significantly reducing the risk. It's pre-treatment. It is not instead of any other personal protection. It's in addition to. So what I've tried to do in these few minutes with the significance of saliva and COVID in dentistry, I hope you're convinced that there are very high levels of COVID-19 virus present in early infection, that we do have receptors for the COVID virus in the salivary glands. And I think the most important are probably the minor salivary glands, not the majors. That the coronavirus replicates very rapidly in the oral cavity and the nose. So we have to think of both sites. And I think we have evidence that povidone iodine mouthwash and nasal spray together can significantly reduce that risk of cross-infection from patients to the dental professionals. Thank you.
Thank you very much.
Thank you very, very much. That was very, very informative. And I think we all learned that saliva, not only is it an important part in our profession, but it also a very good segue into obviously what Yves Cooney is going to talk about, and that specifically is about aerosol, personal protective equipment, and maybe even engineering controls that we need to apply in order to protect not only ourselves, but maybe other patients as well as the surrounding where we're working in. So with that, Yves, again.
Hold on, Mike, a sec. We have something in between the two presenters. Okay. So if we can send to this, in these times, people have to dress up, dentists have to dress up with the overalls and all kind of PPE. And here's a sample of what we can do. Corre video. Okay, we're back, and now, Mike, can you introduce Yves to all the audience?
Sure. So thank you again for the opportunity here to introduce Yves. Yves Cooney, as I mentioned previously, she's Director of Environmental Health and Safety, as well as the Associate Dean of Global Relations at the University of Pacific in San Francisco. She has extensive experience when it comes to infection control in dentistry, and has been intimately involved with many of these guidelines that all of you are using today that have been promulgated by CDC and other organizations. And my understanding is that CDC keeps pushing out these guidelines. If I'm not mistaken, another one came out yesterday or the day before yesterday even. So Yves, thank you very much for joining us, and very much looking forward to hearing what you have to say.
Thank you. And thank you, Michael and Jaime, both for inviting me to present today. And I welcome everyone. I'm going to talk a little bit about infection control precautions in dentistry for COVID-19. Next slide. We all know that COVID-19 has had a huge impact on dentistry. When we look just to a few months ago to COVID-19 or to dentistry before COVID-19, infection control precautions really focused on standard precautions. And those are precautions to prevent the transmission of diseases from patient to healthcare worker to patient, or patient to patient through contact with body fluids. There was a real emphasis on bloodborne pathogens such as hepatitis B, hepatitis C, and HIV. And for many years, dentistry has been considered to be low risk setting for hospital-acquired or hospital-associated infections, as long as those standard precautions were followed. In cases where we did see incidences of disease transmission in dentistry, there was usually a serious breach in standard precautions. Next slide. COVID-19 has really changed all of that with this new focus on aerosols. And Dr. Talicombe mentioned that the US Department of Labor has identified which types of professions are most at risk for transmission of COVID-19 in the workplace. And certainly, and they've created a risk pyramid with 4 different levels of risk. There's low, and then moderate or medium, high, and very high. They've identified dentistry as the very high category for risk during certain procedures with certain patients. So the very high risk procedures in dentistry are those that create aerosols and are associated with treating patients known to be infected or suspected with infection with COVID-19. Other high risk procedures would be any aerosol procedure on patients who are not infected with COVID-19. And then finally, the moderate risk would be providing urgent or emergency care, but not using aerosols. And for that reason, it's been recommended during this period of wide transmission of COVID-19 for dentists to delay any routine treatment and to focus on emergency and urgent care, and to also avoid aerosol procedures. And then finally, the low risk would be other types of workers that may be in a dental facility but don't have direct patient care. Next slide. So in this era of COVID-19, we've seen a number of infection control precautions being recommended as interim precautions. And as Michael said, the Centers for Disease Control and Prevention, the US Public Health Service, issued new recommendations yesterday with a focus on dentists returning to more expanded types of dental procedures beyond just doing emergency care. Something that's very new to most of us in dentistry is the concept of transmission-based precautions. Transmission-based precautions are another tier of precautions beyond standard precautions. They've been used in hospital settings for many years to deal with patients who are infected with airborne transmissible diseases such as tuberculosis, and those that are transmitted by both airborne and droplet methods, which include things like measles and chickenpox, influenza, and others. These transmission-based precautions include things that we haven't really worried about controlling in the past, and that is reducing aerosols, implementing engineering controls such as isolation rooms, enhanced ventilation, high efficiency filtration for our air systems, and even looking at things like patient placement in relationship to airflows in a healthcare setting. And of course, respiratory protection, which is the area that we focused on most in this time of COVID-19, looking at improving the way that we protect our mucous membranes and also our respiratory tract through the use of respirators instead of surgical masks. Also, part of this is including screening both patients and also healthcare providers for symptoms consistent with COVID-19 every day and every time they come for a dental appointment. And further, there have been some recommendations to consider testing of patients prior to generating procedures. And that will be the use of the PCR test to confirm that they aren't currently infected and without symptoms. Next slide. So the CDC interim infection prevention precautions that are recommended for dentistry are for patients where we're presuming they do not have COVID-19. And that is to delay treatment if possible, although these guidelines that came out yesterday acknowledge that, dentists who have been delaying routine treatment and treating only emergency patients are beginning to get back into practice, especially in the United States, where each state and in some cases, each county, subsets of the state, decide when people can start to get back to work and what type of work can continue to be done. Where I am in San Francisco, they've said that dentists can return to work now, but they have to follow certain precautions. So these CDC guidelines are, if it's possible to delay, do so. If it's not possible to delay, then be sure to screen the patient for recent fever, travel, any symptoms of respiratory illness, or an exposure to somebody who's suspected or confirmed to be infected with COVID-19. And if you do have to do aerosol producing procedures, use four-handed dentistry, of course, including high volume evacuation, a dental dam, and other things that can minimize the droplet spatter and the aerosols that are generated by the dental devices. It's also recommended that respirators be worn and face shields if they're available, the chin-link plastic face shields. Next slide. I think the personal protective equipment that's going to be a part of dentistry for some time to come is going to be the highest level available, which includes gloves, although they non-sterile exam gloves are fine for routine dental procedures. A gown, and previously the CDC recommended only changing the gown daily or if visibly soiled. The current recommendation is to change the way that we put on the PPE and the way that we discard it. So a gown is now recommended to be discarded if it's disposable after every patient. Also, the wearing of a face shield or goggles, and then an N95 or higher respirator, and 95 just stands for the percentage of small particles that the respirator will filter, and that's 95%. And that's especially for aerosol generating procedures, but for other procedures as well. And if you are not able to obtain respirators, because we all know that there's a big shortage right now, that a surgical mask in combination with a full face shield would be worn. Next. So respirators have been used for many years in healthcare in dealing with patients with respiratory infections in an inpatient setting, such as a hospital. But they're currently now being recommended by the Centers for Disease Control and Prevention and all other agencies for all aerosol generating procedures in dentistry. The N95 is the most commonly used type of healthcare respirator in North America. Although there are some other equivalents that just have a different designation. In Europe, they're called an FFP2 or FFP3. In parts of Asia, they have KN95s and then others. The difference between a respirator and a mask is that, a mask has a high filtration rate. A surgical face mask generally will filter between 95 and 98% of small particles. And of course, the N95 respirator will filter at least 95%. So similar in the way that they filter, what's very different is in the way that they fit. So a surgical mask is loose. It has gaps where air may enter underneath the mask and come into contact with the mucous membranes of the healthcare provider. Whereas a respirator fits snugly and creates a seal between the person's face and the edge of the respirator itself. And for that reason, it's necessary to have a fit test before using a respirator, because not all respirators fit the same and not everybody can wear the same respirator. A fit test will tell you either quantitatively or qualitatively that the respirator fits and that air is not leaking in underneath that respirator. Also, some respirators have valves, breathing valves on them, and those type are not recommended for healthcare. So for patients who do have COVID-19 or are suspected of being infected with COVID-19, The recommendations are to take airborne precautions, which are the very highest level of transmission-based precautions. Airborne precautions include not only respirators, but the use of something called an airborne infection isolation room. An airborne infection isolation room is specially constructed to control the air in the room by creating negative pressure. So the only way the air can leave the room is through the ventilation system exhaust, and it's exhausted either to the outdoor air or through a HEPA filter. It cannot be exhausted to other parts of the building. There are other requirements such as between 6 and 12 air exchanges per hour, having walls and floors and ceilings that can be disinfected, and that the pressure in the room is monitored. So this is not something that most dental offices or dental clinics have the ability to provide. And for that reason, if you have a patient with an emergency procedure that simply cannot wait, then that patient should be referred to a facility where they do have the ability to provide isolation precautions. And that can be done in consultation with your medical partners. One of the recommendations that's come out of the CDC recently, last week, was because they understand that people are beginning to get back to providing elective healthcare, that they've developed this framework for all healthcare systems to provide non-COVID-19 patients with clinical care during this pandemic. Those things include making sure that you're providing care in the very safest way possible, doing triage through telehealth or teledentistry, following all infection prevention recommendations. And I would recommend going to the cdc.gov website where you can find the most recent recommendations, and that your services may need to expand very gradually and may depend in part upon local epidemiology, are cases declining, inclining, or staying the same, that you're prioritizing your procedures that could cause harm if they're further delayed, and then identifying patients who may be at risk and would benefit the most from your care. Thank you.
That's it.
There are more slides to your presentation. You want to finish? We had 2 minutes.
So one more slide? Okay, I'm sorry. Yes, continue then.
Puedes volver a ponerla.
That should have been the last slide.
Oh, okay.
Oh, I'm sorry, because I didn't say next slide. I'm very sorry. Yes, I'm sorry. This was the last slide in the presentation to talk about continuing or providing your care in the safest way possible. Also looking at prioritization of procedures and other things such as treating one patient at a time rather than having multiple patients in the office, and minimizing the number of personnel that need to be present while they're receiving care. Thank you.
Thank you. Thank you very much, Eve. We're going to go to a very short video and come back. There are a lot of questions, and we are putting them all together.
Si te lavas bien las manos, lograrás prevenir con jabón y un buen tallado tu salud hoy queda en ti. Mas no olvides que tu boca es otra fuente de infección. Cepillarte bien los dientes te protege. Cepillar y lavar es la respuesta. Cepillar siempre profundo cada diente y muela. Cepillar hasta llegar a todos los rincones de tu cavidad bucal. De tu cavidad bucal.
Thank you. Michael, you want to go first with the questions?
Oh, thank you. Yes, please. I have one question for Stephen and I have one for Eve. If I can start with you, Stephen, and I'll talk about both questions at the same time. I'm going to use the word neutralizing. Are there actually antibodies in the oral cavity that can neutralize COVID? I mean, saliva is a magical fluid in many ways and can do a lot of good stuff as well. Are there any data at all available that saliva could actually neutralize COVID-19, number one? And number two, could there be neutralizing antibodies somehow that we could find in the oral cavity as well? So that's for Stephen. And for Eve, you mentioned that we need to change our gowns in between every patient. If you could address, how does a dentist go from doing their own procedures, going and checking hygiene, and then go back to their own patients and back and forth? It's going to be very, very cumbersome, I think, and patient flow is going to be affected dramatically if we have to change our gown in between those type of procedures. So, Stephen, if you could start, please.
Yeah, thank you, Michael, for that question. As soon as I heard about COVID, it struck me that it was essentially a disease of the mucosal immune system. It enters via the mouth or via the nose, it arrives in the lungs, it ought to stimulate a secretory IgA response. So that's one sort of fact or challenge or hypothesis. So there ought to be a response. We have an unusual virus, so we don't know that it actually does so. So I've been scanning the literature. I have not seen any papers which have looked at secretory responses. I happen to know from preliminary research that you can get antibodies to COVID in saliva this is a study of dentists who have had COVID infection. So it does actually produce, this is not published yet, but they can produce antibodies. However, the next stage of showing that antibodies in secretions are protective is a much longer shot. You will know that even with the vaccines, which generate serum antibody, we know that they produce quite high titers, and we know that many, again, in our series of dentists have produced good titers of antibody, but you don't know that's protective until you do your population studies. So the answer, I'm afraid, is that we do not know whether, I suspect that we will have antibodies and they will be detectable, but we will not know just yet whether they are actually protective against or neutralizing against the virus. There are examples of antibodies in IgA antibodies in saliva and secretions being neutralizing, and there are examples where it works synergistically with serum, and so that you have both, you're better protected against other diseases. But it's a long way yet in our knowledge base to show that for COVID.
Thank you. Eve, what about the
thanks for that challenging question, Michael. I think there are going to be a lot of challenges, and this is certainly one of them, because the changing the gowns between patients is a part of transmission-based precautions. So it's been incorporated into our new normal, as they say. So I'm going to say something that may be controversial, but I think you'll like the controversy. And that is it really necessary for the dentist to do a check on every single hygiene patient? So that's number one. Think about knowing your patient, knowing what their needs are, and knowing the skills of your hygienist. And then number two, can you, less controversial, can you arrange your schedule to make it as much as possible so that you don't have to do multiple hygiene checks during while you're also treating another patient separately. So say you're doing, a crown and bridge in one room and the hygienist is in another area. Can you arrange the schedule so that you're only going to see one hygiene patient perhaps during the same time you're treating that patient, so you're not having to change quite as often perhaps?
Thank you.
Okay. Stephen, there is a question for you. Is there any study that will show if the level of COVID in the mouth changes with symptomatic or asymptomatic patients?
Not yet. I mean, the studies which have been done have all been patients who are about to be admitted to hospital. So they are, by definition, the people who appear to have had the greater viral load and viral challenge. We do not know whether people who get COVID very mildly induce antibodies, or indeed show those same high levels in saliva. It could be quite probable that they do show reasonably high levels, but we don't know that yet, because we don't know whether how the virus gets there and replicates. So, in other words, it could be direct infection of the mucosa, but of course there is a possibility that the systemic circulation of COVID will also result in pockets of replication. So we don't know the answer to that yet. I just forgot to answer another point, that antibodies are not the only neutralizing things in saliva. And our experience with HIV, we know that we have at least 3 or 4 products in saliva which are very active against HIV, which are not antibody. So I think when I made that allusion to the numbers dropping off, I think we will find that there are natural protection factors in saliva which do drop off, and it may well be that we will eventually see that people who have those high levels of those factors in secretions may be the ones who are most protected.
And the second part of this question, if there is a place where these saliva markers for COVID-19 are available. Saliva markers, no. I mean, more and more people are using saliva for diagnosis, and only in the last few weeks there have been several papers which say that the nose is much less reproducible than taking a sample of saliva, and the levels are very concordant between the nose. So why stick a dry swab up the nose when you can actually take a sample of saliva? But we do not yet have anywhere near the information of knowing what those factors in saliva which might protect us are. So this is all good research that should keep the clinical academics going for some time to come, but not yet. It can be the combination of some of these products.
Absolutely. I think that's going to be a fascinating question to answer. I'm sure the mouth is going to be the mirror of the lungs and the nose. I think there is a role for academics in dentistry to be able to play their role in trying to understand some of these complexities in due course.
Now there are also questions for Eve. Well, one is to repeat the page of the CDC.
Oh, sure. If you want to look at the CDC dental infection control recommendations, go to cdc.gov/oral health.
Okay.
And then the general COVID-19 recommendations, such as the framework, are just at cdc.gov. In addition to those, if any of you out there are also in academic dentistry, they also issued guidelines for institutes of higher education last week.
And also, many people comment that they have used the N95 mask, and that it's very tiring. If you work long hours, it's very tiring.
That is one of the main problems with N95 respirators. You know, they're not masks, they're respirators. So they do challenge a person's breathing, and not everybody can wear one. And so there are other types of respirators out there, such as purifying air respirators, the PAPRs, but they're more difficult to come by, they're more costly to purchase, but they don't fit tightly on the face. It's sort of a hood that you wear over your head, and it creates a seal, and you have a powered pack that provides air into your breathing space.
Like a scuba dive.
Like a scuba, yes. Dentistry is looking very different indeed when we start seeing things like that.
Stephen, can I ask you a quick question? You talked about the mouth rinses. How long time does it take until the virus repopulates inside the saliva again?
Thank you. we believe that the povidone iodine actually is a very effective virucidal. So the levels go down from the 10 million, 5 logs. So they will kill 99.99% of the virus. We know that what we know and don't know at this point, we know that it lasts at least 20 minutes. And research is going on to see how long it lasts after that before they would come up to anywhere near those sort of levels again. And the answer is it is not known how long that is. It's likely to be, though, more than 20 minutes, which is a conservative estimate. And hopefully that's long enough, along with PPE, for minor procedures and examinations to be performed. And not only in dentistry, it's also a matter of getting tubes down for anaesthetists and ENT people to be examining the nose. So 20 minutes is the start, but we don't have the evidence yet. Research is being done to see how long it actually lasts.
Okay, there are a lot of questions, so don't go anywhere. It's what do you think, Eve, about the overalls that you can wash or sterilize? Well, you already answered that they have to be, you have to change them. Is it the same if you're doing ortho?
The guidelines recommendations, and precautions don't distinguish between the different specialties in dentistry. Certainly, with the reduction in the amount of aerosols that are used in ortho, you can assume a lower risk, but you can't quantify the difference between risks. And so therefore, the precautions are droplet precautions. So that would be for not only aerosol generating devices, but also if a person were to cough or sneeze. And the changing of the gown between each patient is an element of droplet precautions. So therefore, the long answer to that question is yes, the same type of rule apply. I don't have necessarily an opinion about reusable versus disposable. I do personally like the reduction in waste if you can manage to have reusable. There's nothing that requires that they be sterilized. Laundering should be adequate for reusable protection, such as gowns or overalls.
Okay. Well, I think the logic is, Michael's going to kill me, but the logic is that if you can wash your hands and get rid of the COVID, you can wash your garments and they will get rid of the COVID. The soap will get rid of the, I don't know if you want to bring those things home and put them in the washer and the dryer. I don't know. It's, very soon we're going to see washer and dryers in the dental offices.
Yeah. And in the States, that's been the case for many years when the Department of Labor issued the bloodborne pathogens rule way back in, I think the first one was 1992. That was part of the requirement, is that if you had reusable gowns or protective attire, that could not be taken to a person's home to be laundered. It needed to be laundered either on site or by a professional company.
This question is for both of you. Stephen, if you can answer first. Would it be wise to put any kind of bactericidal? There are like 10 questions in that regard. Some dental units are not connected to the water pipes. They have a reservoir with water. And if you could add, of course, iodine not, because you're going to make a mess of of everything with the iodine stains. But if you put peroxide water at the right amount, would it be wise to use it in your handpiece? I know, or is there any research on if we can use any antivirals to kill the virus before it becomes an aerosol? I don't know. But then we will be breathing that thing as well, right?
Interesting. There's lots of evidence that these preparations are basically detergents. And there have been lots of studies which have looked at how long the virus lasts on surfaces around the dental surgery, for instance, on hard surfaces. And most of these agents will actually be quite effective at cleaning and disinfecting those surfaces. So that's an absolute must. They should go on at the same time. There isn't any evidence of the virus initiating within the water cooling systems. I used to do a lot of work at one stage on Legionella, and in a way that was a marvelous way of the droplet size in sprays was exactly the right droplet size to be deeply inhaled. So for the spread of Legionella, and that's a different thing. That was a must, that one should look at ways of eradicating that. I see no direct advantage here in using these detergents within, even though they're very virucidal, in units which don't have any evidence of that route of transmission of virus. I do see them being very important in all the hard surfaces, and I do see them being very important in reducing the viral load in patients sufficient time, and they, of course, can be repeated for sufficient time to reduce that risk to the dental personnel.
I also think too, Jaime, if I can just chime in here, is that people need to be cautious about adding agents to their water reservoirs that are going to go, through your dental equipment and come into contact with the patient's mouth. There may be compatibility issues with your equipment, and there also may be compatibility issues with, dental restorative materials and things like that, because I know over the years, people have tried many different things in those water reservoirs, and some are not advisable because of damage to the equipment or incompatibility with dental materials.
Steve, talking about reusability, what about reusing N95 masks, number one? And number two, what about UV lights? Is that something we should consider?
So for the reuse of N95 respirators, it's not recommended. What's happened, though, during this outbreak is something I don't think that any of us ever imagined, and that is that the world cannot produce enough personal protective equipment to provide what's needed by the healthcare professionals. And so therefore, interim guidelines for optimizing PPE have been issued. I just had a conversation, as a matter of fact, with CDC this morning. We were talking about this very topic. And that is that some people have taken these guidelines, which include the reuse of N95 respirators, and applied that to situations where there wasn't either a critical need or where they were doing routine procedures. And the reuse of any single-use item is only intended for these very critical emergency situations. So, people working in hospitals treating patients with COVID-19 or other emergency needs, and they don't have enough N95 respirators for everybody, they might reprocess them using, there's 3 different methods that have been said that have been identified as being appropriate. But under normal circumstances, this should never be done. And all other controls should be in place first, such as you've reduced your care to only treating patients who have emergent care, because otherwise you're putting yourself at risk.
What about the UV lights?
I do not know enough about UV lights to give a definitive answer. I do know that there's several different things that they've looked at. One is UVC, which of course, most of the UVC technologies have to be used in a room where there are no people, because it can cause cause harm to skin in your eyes. And then there's the upper level UVGI, the ultraviolet gamma irradiation, which actually appears in the new CDC guidelines. So I am curious and it's not referenced, so I am curious as to why they selected that as one of the controls and kind of rejected others.
Stephen,
personally, I don't have an opinion on that.
Stephen, many people have asked us to put the slide again. If you can go over it one more time.
Is this the slide on the use of the mouthwash? Yes. So I should stress, first of all, that using a product to reduce the levels of virus in saliva is additional to, not instead of, using all the other PPE. but it seems to me a very sensible precaution to do. Because a few microliters onto the spittoon or the cup, there's a lot of virus around. So, and I hope I've given evidence that the nose must be taken into account as well. And so this is two-stage. Stage one, as you see there, with that nice picture, the 1964 picture of the very first picture of a coronavirus, which is incidentally rejected by the Lancet because they thought that it must be a mistake because it had the halo around it, which they named Corona. So Corona was named at my hospital. But the first stage is to do a light spray up each nostril, and it's 0.3 mLs. Now, ideally, that's a little spray with 2 puffs up each nostril. Just press, puff, 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 and it's a little stern sniff. And that there is evidence that is sufficient to reduce significantly the amount of virus in the nose. We in dentistry, I think, are of course, familiar with the second part, which is to take, this is 0.5% povidone iodine mouthwash and move it all around the oral cavity. We suggest that one should try and get it back to the back of the mouth by doing a gentle gargle, but not so much that you're in risk of forming an aerosol in its own right. It's really just to make sure you get all around the mouth. And then it's, of course, back into the spittoon, because it actually seems to kill within, certainly within 30 seconds. We would expect that at the 1 minute when it's expectorated into the spittoon, that it would be only have dead virus, or at least 99.99% has been killed. So, and that can be repeated. So that's our view, is that all patients being seen, that this is a sensible way to reduce that risk, whether you know they're positive or not. In due course, we will be able, I think, to have point of care diagnostics, which may be able to help us in that and know who is and who isn't. But it's not quite there yet, and not out for the professions. So, and I have put a little thing there. My colleagues who are treating on the front line COVID positive patients do this themselves every 2 hours during their on-duty periods to reduce that risk of cross-infection. There's less evidence base for that than there is for the two-step approach, nose and then mouth, that I put on this slide.
Okay, la retiramos. Well, you don't know how many questions. My telephone is just bzz, 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 bzz. So I think we're gonna have to invite you again soon, because we are almost 10 minutes past the hour that we agreed on. Maybe one last one. They're asking a lot about brands of good masks. Are the Chinese good? Are the Korean good? Are the American good?
I'm assuming they mean the respirators rather than the surgical masks. Yeah. The problem with, so the European and the US produced masks, I think you can rely on. They've gone through the proper.
Not TV. It looks like TV, but it's not TV.
Yeah, so I think the problem that there is with the KN95s out of primarily China, but some other parts of Asia also, is that there are a lot of counterfeits. What they've done in the US is the Food and Drug Administration, the FDA that regulates these things, has created a list of KN95 and other types of respirators that have some evidence that they're at least approaching equivalency to the N95s. The difference is that in the United States, every N95 that gets approved is tested by the National Institutes of Occupational Safety and Health, and the KN95s are not tested. And again, there are many that are not authentic, and when you receive them, if they feel very flimsy, and a lot of them are not much more than tissue, they're probably not a true respirator. And you have to do a fit test also. If they cannot pass a fit test, then they're not going to be functioning. They're not going to be providing the protection that you need.
Okay, we're going to see a short video because we're launching a campaign on TikTok, which is the new app that has made possible to be at home for so many days having fun, doing videos or watching other people doing nonsense on videos. And we launch one with the same music, so podemos correr el video, and then we come back to you. Don't leave.
Si te lavas bien las manos lograrás prevenir con jabón y un buen tallado tu salud hoy queda en ti. Cepillarte bien los dientes te protege. Cepillar y lavar es la respuesta. Cepillar hasta llegar a todos los rincones de tu cavidad bucal.
Okay. Well, you can take your Colgate toothpaste, your toothbrush, you accommodate your telephone, and you can do your TikTok and try to use the same music so we can make it viral. A lot of dentists have already uploaded their videos. Michael, we're waiting for yours.
For those who didn't see it during the break, I did my dancing to the music, but I don't think you want to see that uploaded.
Okay. Well, Michael, you all want to say like a last round of opinions or whatever you want to say?
I'm so sad and I am disappointed that we cannot continue this conversation. I think it's been extremely important to hear what both of you have to say. Your insights, your experience, your knowledge is invaluable. And I certainly hope that we will be able to invite both of you back again and hear more. Because when it comes to COVID, number one, COVID time is a new perspective. Everything changes so very, very quickly. So that's number one. And number two, I used to say that, we are flying the airplane and we're building it at the same time. Meaning we are trying to figure out where we're going, we're improving, and we don't know if it's going to work yet, but we have to use what we have. And I think we're doing a great job. The last thing, though, if I could ask both of you, sorry, Jaime, both of you one single question each. How do you think the COVID-19 pandemic will change dentistry?
I think Eve should go first.
Well, I think that, I've been in the infection control field for 35 years now, and I think things changed a lot with HIV, and they're changing even more with COVID-19. And so I look at it, not that I'm happy it happened, but it's a real opportunity to get people's attention and to finally to realize that dentistry is an area of risk both for providers and for patients, and we need to be vigilant and constantly updating and making sure that we're doing what we need to do to keep people safe. But I think there are no guarantees. There's nothing that's 100% safe, but I think that we can create a safer environment and a place where patients feel comfortable coming to be treated.
Thank you. Stephen?
I was going to echo the same things. I've been in dentistry for a long period of time, but well before HIV. And I think that it was really hepatitis before then. And then HIV, it did change our method of practice. But also it changed our, I think, understanding of the nature of dentistry and infectious viruses in our environment in which we work. I think COVID is taking this a stage further. We are going to live as a society, I think, with COVID around. I think we will come to terms with the amount of PPE that we need to safely practice, but it will alter our practice in the long run. But it's important that we do. None of us came in to be clinical in a healthcare profession to only treat healthy people. So the dentistry has got to find a way of getting back to work and being comfortable, not only for patients, it's got to be comfortable for the dentist, and we have to make sure that our nurses and our hygienists are also, and I might say dental technicians, are also comfortable with the new environment. So we have a responsibility to treat patients when COVID is around, and we must meet that responsibility.
So it sounds like both of you are saying that we still have a social contract, but the clauses in the social contract is changing a little bit.
I think so.
Well, Michael, I think that paradigms are there to be broken. And if you had asked me in January if I would be doing a program like this with you, I would probably say, no way. That's not in my future, or neither was in yours. But, you know, this is just a small change that COVID has made. I think we have the opportunity, and we have to grab it, to explore all the needs of the dentist. No matter where they practice, we are being watched in all the 5 continents of the world live, and this will stay in social media. I would like to say forever, but nowadays I have a hard time knowing what forever means. So I really want to thank you, Eve, all the way to San Francisco. Stephen, all the way to London. Thank you for your patience with the rehearsal yesterday and the program today. Mike, I only have a big thank you for you. And Samantha, which has been doing the translation to Spanish in our social media. Thank you very much, Samantha, for your work. I remind you that we all are here in this program in a pro bono way. These are the guests we're going to have next week. He's going to be my good friend, Professor Isan Benyaya she's a professor at the Dental University in Casablanca in Morocco. And Yasmin Crystal, which is we went to dental school, in the same dental school, not together. She's younger than me, as you can see. But she is a specialist on doing, now I know why you wanted her back, Michael. Can you put the 4 of us back? Nos pueden poner a los 4. She explained me that what she does is that she takes all the evidence and makes it easy so we, the eminence, can understand. So now I know why you you recommend her for the program. Well, I also want to remind everybody that this Wednesday we're going to have a special program on congresses and the future of dental exhibits with Mr. Ayub Safar, who is the organizer of the AMIC, Agrupación Mexicana de la Industria y el AMIC Dental. We're also going to have my good friend Fred Friedman he's the president-elect for IDM, International Dental Manufacturers, and my very good friend from Berlin, Mr. Torsten Oemos, who is the owner and director of Dental Tribune. It's all for now. We thank you very much for being with us. And thank you, Eve. Thank you, Stephen said. Thank you, Mike. Thanks, everybody at the production, both in IDE Academia and in Produce in León, Guanajuato. And we'll see.
Stay safe, everyone, and make smart decisions.
We'll see you next Friday.
Take care.
Bye.
Bye.